The next speaker, in case your brains weren't about to explode, we have one more speaker, and then we'll be able to try to integrate all of this. Next is Shaina Stacy. Shaina is a postdoctoral scholar at the University of Pittsburgh Graduate School of Public Health and the UPMC Hillman Cancer Center. She uses geospatial methods to study cancer outcomes and environmental risk factors in UPMC catchment areas. And in particular, I think she's going to talk about unconventional gas development in this area. And she will give you a preview of her research on that topic.
Hi, good afternoon. Can everybody hear me? Okay. So first, I just want to thank Molly and Polly for inviting me to speak today. And when they invited me to speak, they asked me to touch on both previous research that's been done in the area of unconventional natural gas development and childhood cancer, and some of our ongoing work using Pennsylvania data. So I'll be doing both of those things today. And I'll also preface by saying I think this is another good example of an area in which, you know, Dr. Kripke was talking about reactionary versus the precautionary principle. And this is definitely an arena where we sort of charge forward with some of these unconventional gas extraction activities without really monitoring the health effects. And so now science sort of has to do these studies now and try to catch up and see if anything's going on. And so if you look in the literature, a lot of people use their own abbreviation for these things. Mine in this presentation will be UNGD. Sometimes I might use fracking, which is the term I'm sure a lot of you have heard. But UNGD is really an umbrella term for two processes. One is horizontal drilling, and the one is what more people hear about, which is the fracking or hydraulic fracturing component. Both of these are used in order to access gas, natural gas, or often oil deposits that are buried deep within the ground, tightly bound in shale layers. And so you can see this cartoon diagram of a well being drilled horizontally through the shale layer, and this is happening thousands of feet below the ground. And in the fracking process, millions of gallons of water mixed with sand and a small amount of chemicals are pumped into the well at high pressure to fracture the shale around the well so the natural gas can then flow back up freely. And I just like to show this slide to show that this isn't just an issue for us here in Pennsylvania or even just the United States, but there are oil and gas shale plays all around the world. And just in general, before we get into specifically cancer, there have been many other human health impacts that have been studied in relation to UNGD exposure. Some studies have reported increased complaints of noise, odors, and even just people experiencing stress. There have been now quite a few studies that have looked at adverse birth outcomes, including our own study a few years ago in southwestern Pennsylvania, where we saw that mothers living in close proximity to UNGD, that their babies were at higher risk for being born with lower birth weights. Also, other studies have found things like increases in adverse nasal and sinus symptoms, as well as asthma exacerbations and even migraines. And I also think that this morning we got some very good background from Dr. Miller on childhood cancer, so we'll just breeze through this a little bit. We know that cancer in children is relatively rare, but it does remain the leading cause of death by disease past infancy among children in the United States. And we still know very little about its causes. And I would like to go over quickly this figure, which is just showing you a trend in overall childhood cancer rates for the state of Pennsylvania using registry data. This is over a 25-year period. And like I said, it's a relatively rare outcome. The rate has seemed to sort of fluctuate very slightly between maybe 13 and 16 cases per 100,000 people, with maybe a very, very slight uptick in later years. Dr. Miller showed that national trends seem to be that childhood cancer and childhood leukemia is increasing overall. We know that leukemia is a cancer that occurs when the bone marrow produces abnormal white blood cells. And that in childhood leukemia, this develops very rapidly. There are several subtypes, the most common being ALL, which we again heard about this morning. And in the context of UNGD exposures, as well as several other pollutants, which we'll look at in the next slide, one primary pollutant of concern is exposure to benzene due to UNGD, because that is, as we know, is an established risk factor for leukemia. And so previously, and this was a figure also shown in one of the earlier sessions. This is from a review by Elliott and colleagues. And they started out with doing a literature review, really. They compiled a list of air and water pollutants that have all been associated with UNGD activities. And they used the IARC monographs, which we've also discussed today, to categorize these pollutants as being established or potential carcinogens. And using this method, they identified 20 unique compounds that had some evidence for an increased risk in either childhood leukemia or lymphoma. And I have some examples up here. You can see things like benzene, 1,3-butadiene, cadmium, and diesel exhaust, to name a few. And so now we'll move into the more specific studies that have been done looking at UNGD and childhood cancer in human populations. I do want to mention, because I've had a few earlier questions about this, why are we studying childhood cancers and what kind of other cancers might we be studying? Well, I will say that in addition to just personally in my own research, I am very interested in childhood health and identifying early life exposures that can affect the health of a child. Things you're exposed to when you're young, whether that's in pregnancy or very early infancy, can have an effect on your health all across your lifespan. So that's a very important time period for prevention. In addition to that, with the practicalities of research, if we're going to see effects from a new or emerging industry, children are in some ways very practical to look at. If there's going to be a health effect, we will see it much more quickly in children than we would in adult, whereas we know it can take decades to see a cancer develop. And so with that in mind, we'll go through a few of the previous studies first that have tried to look at this. The earliest was Fryzek et al., and they actually did use Pennsylvania data. Their study was published back in 2013, and they were basically comparing rates of childhood leukemia and central nervous system tumors in Pennsylvania, and they were comparing them before unconventional drilling began and afterward. However, when they did this, they really didn't see that there were differences in the observed number of cancer cases compared to what you might otherwise expect. And they didn't see any differences before and after unconventional natural gas development. However, the caveat was that at the time, they only had cancer data maybe going up through 2010 or 11, something like that. And we really just started drilling in the state in the mid-2000s. And so Dr. Goldstein, for example, came with a reply saying, look, there really hasn't been a long enough latency period to really see anything yet. Also, a little bit later in Colorado, Lisa McKenzie and colleagues, her group has done a lot of work looking at health effects of UNGD. They looked at childhood cancer in relation to proximity to UNGD. As you will see, a lot of these preliminary studies use proximity or well density as a surrogate for exposure. And that has to do with a lack of measurements and also funding to kind of go out and take actual measurements of exposures in air and water. But they found, they did see something. They found some age differences as well. Their big finding was that, so these were cancers in children and young adults, that 5 to 24-year-olds diagnosed with ALL, so that's that most prevalent subtype of leukemia, were 4.3 times more likely than their controls to live in more densely drilled areas. And that's their results in a nutshell, obviously. It was a case control study. Now their odds ratio of 4.3 The confidence interval is 1.1 to 16. That's actually very high for an environmental study. Usually I'm not dealing with odds ratios that high. So it is a bit of an almost alarming to look at. However, when they were looking at the different age groups, they didn't see any effects on their youngest children, and they didn't see anything related to non-Hodgkin lymphoma. So their results were sort of tied to one age group, and specifically ALL. And so we have been trying to look at this in Pennsylvania as well. Now we've been fracking for a much longer time period than when Friesick did their study. And so I sort of have a wordy slide about our methods, but I'll walk you through it. Basically, we have a registry data set from the state. We have every birth record in the state. We actually go further back, but since we're talking about fracking here, which started, like I said, in the mid-2000s, we're talking about births that occurred from 2007 to our most recent year of data available, which was 2015. In addition to having every birth record, we also have cases of childhood cancer that were diagnosed in this time frame. And each of these cases of childhood cancer is linked to their birth record. And the significance of this is that in addition to fracking, we are interested in other environmental and maternal risk factors for childhood cancer and infant risk factors. So we're looking at a bunch of different things. Today we're talking about fracking. The idea being that, again, something that the mother or the infant might be exposed to early on is affecting the child's cancer development later on in their childhood. And similar to our previous work and the work of others, we are using, and we'll look at this in the next slide, something we call an inverse distance weighted well count, which is simply a metric that's taking into account your proximity to a well and also the density of wells around you based on where you live. And so to calculate this, from the birth certificate, we have where the mother lived at the time her baby was born. So again, we're doing an exposure assignment based on where the mother lived to see if an exposure at that time period is affecting your development of cancer. From the oil and gas well inventory from the state, which is actually publicly available online, we also have estimates of when wells were drilled, when they commenced drilling. And so in this metric for each mother, we're starting out by including wells that were drilled, or in their jargon, spudded, during a 1-year period up until the birth date of when the baby was born. And the type of model we're using, so it's not a case control design, it's a cohort study design. We are running time to event models, again, to get at that latency period and exposure occurring in the past at the time the baby was born, and looking forward in time to seeing their cancer development. In my world, this is a Cox proportional hazards model. But if that's too much of a mouthful, you can just think of it as, it's all retrospective data, but there's that prospective component to it of timing of exposure and later development of the disease outcome. And as you'll see, we're taking into account other risk factors that might be related to childhood cancer. So just briefly, this inverse distance weighted well count. We're drawing a 10-mile buffer around the black dot, which is, let's say, where the mother lives. We have these green wells within the 10-mile buffer. We're using a geographic information system software to determine the distance from where the mother lived to each of these wells. We're taking the inverse of the distance and adding them together. Again, all that's really doing is giving greater weight to the wells that are closer to you. And that's all being accounted for in this IDW well count metric. And this is just a figure showing this is just a snapshot, not even time trends or anything like that, showing counts of childhood cancer cases in the state compared to where they're drilling. And as you can see, again, these are counts and not rates. But of course, we're going to see higher counts of cases in the cities just because that's where a lot of people live. But I wanted you to see, they're drilling primarily in our portion of the state as well as up through central and northeastern Pennsylvania. So some results. So we've run this a few ways. These are the results for this IDW well count metric and risk of total childhood cancer. So on the y-axis, we have HR as our hazard ratio, our estimate of risk. On the x-axis, we have these. So after we assign every mother this IDW well count, we're dividing her into an exposure group, basically. So we have a comparison group of everyone who lived outside of that 10-mile buffer. That's our sort of non-exposed group. And then we have these categories of increasing exposure to fracking. And you can see that in the unadjusted model, for the mothers that were living closest to wells at the time of their pregnancy, that their children do appear to be at a higher risk of development of any cancer. However, you can also see that when we start to account for some other more individual level risk factors, that we call that that result is slightly attenuated, which means that the confidence interval now includes the null of 1. And also, something else we're adjusting for, we know that in the region we're exposed to lots of other different things, and there are probably many other environmental pollutants we could be co-adjusting for. In this model, as a first, taking a first stab at that, this is adjusted for traffic. And in this case, it's a surrogate for traffic exposure, which is this PennDOT collects it. It's a traffic volume, and it's the traffic volume of the road that's closest to you, essentially. And so when we try to look at, so we know that obviously this group of childhood cancers, there are many different types of cancer within this. It's a very heterogeneous group of diseases. So now we try to look at it by type of cancer. And when we do that, actually, this hazard ratio gets attenuated further. And another thing I wanted to note is that we're really not seeing a dose response either across exposure groups. And so whatever is going on with the increased risk for any cancer, is there a chemical that's responsible for an increase in risk for such a heterogeneous group of diseases? Probably not. Maybe there's something else confounding it or something else associated with drilling that could be resulting in this. However, when we start to look at specifically leukemia, this seems to get attenuated a lot. Now, this isn't to say that, definitely not to say that the Colorado study is wrong. This is obviously, especially in southwestern Pennsylvania, we have a lot of competing exposures where they're drilling in southwestern PA, for example, even though it's surrounding Allegheny County, and it's definitely not urban like the city center. It's also definitely not as rural Colorado. So I think this is a complex issue. And if there's one thing I would want people to take away from this, it's, regardless of whether fracking is causing or has an association with childhood cancer, I think there's been a wide enough health effects literature that still supports policies and regulations that protect communities. There's a emerging, like I said, literature looking at adverse birth outcomes. We know a lot of these pollutants associated with drilling are not only carcinogens, but are associated with things like lower birth weights, preterm births. And so one of the ways in which they can regulate this at the policy level is through setbacks, which is how far away from, communities and schools and playgrounds, places where kids might play and live, how far away from those places are they allowed to do this? So that's one example. We're talking about potentially modifiable factors here. And I also have at the end some recommendations as far as future research goes, just in general for UNGD and cancer, but really any health effect. And I have to wrap up. But the biggest one is really that for practicality reasons and to sort of take a first cut at trying to study these things, we use these proximity and well density metrics, and we should do better. We should do studies with more individualized exposure assessments, and I have some recommendations for that up here and would be happy to talk about them more during the question and answer session. So thank you.